Alors, on va démarrer la...
So we will start the very last round table for this morning, and Guy asked us to do something that is probably not really, we're not really used to. So just to introduce this question of quality, we would like to take an example from the previous round table that has been presented by Emmanuel de la Taille, who said that quality of care for me, if I were ill, was for the surgeon who would be operating me, would have to be having a surgery by a colleague who will be qualified just as he is. So I think that this is something that actually changes a lot, quality of care and things like that, so that to make things evolve in the positive direction. But what also impressed me during this first round table is to know that the notion of the quality of care is a consensual thing, because we do not really see it all in the same way, meaning the patients, the healthcare professionals, the institutions, we all have different points of view. And I actually will probably start by giving the floor to Françoise, because I actually wanted to hear what she thinks about our way of defining and measuring the quality of care, whether it does correspond to what the patient expects from the system, whether the patients are happy, satisfied, whether the use of the healthcare system is the correct one. So the answer is no. Nonetheless, we still can hear that we have to work with patients, and of course we have already understood it, and thank you very much to all of you for that, that patients are not an excuse. And this is something that is always accessible to all of us, meaning to make sure that all of us, because we all, like 30% of the population is ill, so we are all concerned by all of this. So there is a very important point here. The patient is vulnerable, and that's the first point. So the patient leaves their medical journey in a difficult way, and I would like to tell you that as a proof, I have seen 6 people before 9 o'clock, and they came to see me just to tell me that, well, of course, there are some who will be deciders, and this 6 people will be making their decisions. So they came to see me and told me that the surgery went so badly, and the medical journey was also very bad. So there is a real problem in the field, and one of the examples is, of course, the therapeutic education, because it was done from top to bottom, and of course this did not breach the gaps, and the patients are not satisfied, and we only have 3% of patients with chronic diseases who would be more or less in a good situation. And I will go back to the artificial intelligence a little bit later. I also went to China. I wanted to talk to you about this trip because I was very much impressed by the Chinese patients who would receive a medal concerning the quality of life and experience of the patient. And these patients were not diseased. These patients were in good health, and they actually had this very good red star because they were considered like examples, because they were in good health. And they well worked with their practitioners and with their institutions, and they were working in the preventive part as well. And I was also very impressed to hear Etienne Maviel, who said, yeah, there was this patient who told me, I called you 3 times. Well, when we know that 2% of patients are called and the others are never called, now the question is very important. So I would tell you that in the field, there's a lot to do, really a lot to do, knowing that the patient really leaves their medical journey in a chaotic way, because the patient understands, and their vulnerability is very, very important, as I have already said. So whenever there is a symptom, whenever there is a drug or something like that that is introduced, so the vulnerability is very important. That's the vulnerability of the diseased. And there is this very important lack of coordination, because very often the patient or the diseased is the coordinator, but that's not the right way of doing it. And I'm not even talking about the lack of empathy, because we actually know it, that this is something that we need in order to feel better, not only to save the costs because of the pain, because we have 20 million chronic diseased in France, and empathy is part of the coordination, but it's right now a different thing, and it's right now apart from all the coordination and everything that is happening in the field. And the very last point that I wanted to mention is the anxiety. This is something that is present. We have already seen it. We have this anxiety from the point of view of the institutions, but also of the patients, of the population. I have heard this term, population. Well, we are representing the population. So there is this anxiety at the level of the population, but also at the level of the healthcare professionals, not just practitioners, but also pharmacists, etc., etc. And this is also bad, without even talking about the eco-anxiety that Anne-Marie Monteras has already mentioned. So this anxiety will be blocking and the responsibility will also be blocking the reality itself. And there is this very important difficulty that arises, which is the difficulty to talk to one another. So just to finish, I would like also to talk about the good treatment, because we also have to look at this point of view as well, whether our system is a good organization for the health and if the treatment is really good here. Well, the answer is actually no. So I think that this is a big issue here, and we actually have to look at it without talking about guilt, but look at all the responsibilities and things to do in the field, because we have a lot to do. Well, thank you so much. We will go back to it, and this is why I actually wanted to give you the floor first. But we also understand that whenever we are the president of the only trade union for the nurses that is not opposed, well, we actually have some others of them, well, that is not against the fact that the caregivers will also have additional trainings in order to become nurses. I also wanted to mention all of this. So what makes the quality of care? How do we measure all of this? Is it just the care from the nurses, or is it all of it? Coordination, coherence, consistency, and things like that in all of the health-related journey. And what I wanted to say is that we cannot really talk about quality and this notion of quality without talking about the ecosystem where we are carrying out all of the activities and the organizations that are carrying out this treatments and this care. And this is something that they have mentioned in the previous roundtable. So that's the first point I wanted to mention. And the second point is to see how in this system all the stakeholders will organize themselves in order to really measure this quality. And we cannot talk about the measure of the quality without talking about who will do this, because today we cannot say that the quality will be measured without mentioning who will be doing this, because otherwise it will be like talking about this construction that we will be starting with the roof without having the basis. So that's what I wanted to say just to start. And behind all of that, of course, we have a lot of things to say about the technostructure, and I don't want to have a negative approach here, but we were talking about this this one window approach. And the thing is that we are having here a structure that is probably a little bit much more re-centered on the activity of the caregiver and within the framework of the national strategy of health. And this approach of care at home is also very important today. So we actually have to ask ourselves the right questions. Let's say talking about the aseptic treatment at home for the Diogenes syndrome diseased is not the same thing as talking about the aseptic care in the operating block in the hospital. So all of this are the important questions that we are asking ourselves. So it's important to take it into account whenever we are talking about all the organization of all of this. And we also have Frédéric Picard, who is with us, and he is working in Scotland, and he also he's also sometimes working in France, because here in France everything is so well and works so well. But whenever we are talking about things that happen in Scotland and the evaluation of the quality, well, I was very much impressed when he shared with me his experience. Well, I would like to tell you that not everything is as bright as you're mentioning it, but I just wanted to bring forward my experience, because it's been 20 years since I started working in one of the biggest establishments of surgery in Great Britain, and it's based in Scotland, in Glasgow, and it actually treats 5 million inhabitants of Scotland, all of Scotland. So the measure of quality is one of the most fundamental things that we have here. So for this hospital, they have 4 types of specialty: orthopedic surgery, they don't have traumatology, they also have cardio surgery, which takes western part of Scotland. We also have cardio surgery, like the classical cardio surgery, and we also have the ophthalmological surgery for some of the diseases. And this hospital was bought by the NHS in Scotland 3 years ago, so that to absorb this waiting list that you have probably heard about, that starts increasing in a very terrible way throughout the Great Britain, which is why the NHS has a very negative reputation right now in the media. So just to talk to you about the situation when I arrived in 2003, there were patients who waited for 5 years to get a prosthesis. So these patients were in an absolutely catastrophic state, depressed and with hypertension, diabetes, obesity, and of course a lot of pain. And the government tried very hard to find solutions, and one of the solutions was to buy this hospital, because this was a private hospital and they actually had a 4-star hotel inside. They also had a conference center inside this hospital, so it was a very modern structure. And this is why, little by little, they started making calm all the patients who didn't have their surgery after 3 months, no matter what would be their trust, no matter what would be the hospital in Scotland. So it could have been a hospital in Inverness or Edinburgh or any other. So the quality had to be measured immediately, because you can just imagine in the region, let's say in PICARD region, all the patients who needed a prosthesis for their hip or for their knee, and they had to have their surgery in Nice. So if this person has to come from Marseille or from Montpellier, so first of all, you have to make sure that the patient is happy. Second of all, you have to make sure that the staff that will be taking care of this patient is skilled and competent. And thirdly, the institution must be able to absorb all the errors and deal with all the errors and complications and things like that. So just very quickly going to this situation. So for the patient, it was fundamental. This was the very first criteria. The patients, all of them from the very beginning, and still now, they have all received questionnaires. These questionnaires were here to evaluate their satisfaction, not only the satisfaction by their treatment, but also by food and by the care in general, the overall care, everything that we're having in the hospital. And it will probably be surprising for you, but the rate of satisfaction was of 98% and still is the same despite COVID. The staff, and here, just as we have heard previously, of course, we have something fundamental that is present, which is the organization. And we have already discussed the point related to the organization for some time, and it was very interesting with all the discussions that we have heard. So the information, which is a fundamental point here, and just to give you an idea, all the general practitioners and all the doctors are evaluated every single year. And this is an independent assessment. And every 5 years, there is a recertification, revalidation. So if this recertification is not passed, the practitioner can no longer work. So this is the General Medical Council, GMC as they call it, and this is the council that actually gives the right to work to these doctors. So the team is also a fundamental component here, and it is permanently audited, so we have to audit them and to make sure that the teams are working well and are well coordinated, in particular with respect to the patients and the length of their stay in the hospital. Let's say for the hip prosthesis, they have to stay 3 days or 4 days, and all of these assessments and evaluations are consistent and permanent, and they're not only done at the local level. Let's say whenever we have some problems during a surgery or something like that, the staff can fill the D-tax form that will be also evaluated later on. And this assessment is also done at the level of the institutions for the prosthetic surgery, and this is done at the national level, so it's called the Scottish Arctic Project, and you can see it online. So this is the register of all the prostheses. Everything for all the establishments is recorded there and is compared as well. So we receive this data. If, for example, I have 3 side effects within 1 month, then I will have to explain what happened. I will have to look at it file by file and provide the explanations and also find the solutions. It's not to make me feel guilty as a practitioner, but it's to make sure that the practitioner moves forward and improves, and to understand also what happened in each particular case. So just to summarize, because I don't want to take all your time, so all of these measures are at the level of the patient, but also at the level of the staff members and at the level of the institution as well. And this is, I would say, back and forth, a constant back and forth of all the different assessments, evaluation, trainings, and improvement of all of the medical quality. And also you were telling me that this was a positive process, right? So we are not really looking to punish someone, but we are trying to improve the system in the from the overall point of view. Yes, well, thank you very much. With respect to the experience of Frédéric and everything that Frédéric knows about France, well, this high health authority actually did a very important change at the level of the care. And Olivier Véran, I think starting from 2021, asked to take into account more and more the quality of care and the quality of life of the patient. And the how does French health authority perceive this problem, and what are the solutions that they're offering? Well, this is actually very good, because a lot of people in the previous roundtables have already talked about this AHS, French Health Authority, about how we measure the quality, the relevance, and the safety of all the care. And this is something that is already done through a lot of things. First of all, in partnership with all the users, well, the patients, of course, but also all the other users, because we also have medical and social establishments that are part of our skills and our competencies. Also, with the professionals, with the teams, not just the healthcare professionals, but all the different teams and professionals that are somehow related to the medical care or to the follow-up of all of our users. And of course, we are trying to have as much as possible of transparency, independence, and rigor, because these are the 3 very important values that are in the very heart of our mission. So how are we doing all of this? Because yes, indeed, the experience from the Scotland that has been explained to us is very illustrative for us, because we have a lot of indicators for the quality of care. We are developing approximately 50 plus of them, and most of them are part of all of this horrible acronym EFAC, which is the indicator that is the indicator of the financement of quality. And at the very beginning, this was the indicator that was created to make sure that beyond all the motivations given by the example and so on, we would build up an indicator with the users and with different teams. And the idea is to actually go back with all of this to the file of the patient, to go back to all of this, to see how we can improve our practices, because this is not, once again, the approach to punish, but to inform ourselves and to get this transparency in order to improve, because we're comparing ourselves with ourselves, first of all, to have this improvement, but also comparing with other teams that are doing similar things. So it's basically quite aligned to what has been said. And this was the indicator of the quality of care at the very beginning, and probably Marie will be talking about it later on. But this was the indicator that was created in order to motivate all of the institutions to commit for quality, and starting with additional finances. But unfortunately, the system became a very centralized system, and for a very centralized system, sometimes it gives this feeling to the users, the feeling of something very technocratic and very aggregated, something that actually has not a lot of transparency and comprehension. Nonetheless, this is the topic that we're still working on. So yes, indeed, I understand we have a lot of things that that are developed at the level of the French High Health Authority. So we had these questions at the roundtables. One of these questions is the certification of the healthcare professionals, because that's part of the core of our jobs, because all of these jobs, most of these jobs are certified by HAS. And so here we're talking also about the journey of the patient. We're including the patients in our whole process of certification. And for each new version of certification, we always have this feedback from the experience, so that's to be able to elaborate the next version that will be improved and that will include all the expectations of our experts and users and visitors. Just to tell you, we are right now at 1,000th visit for certification in France, and all the visits of certification are done by us. And during this visit, we have approximately 1,000 visitors, experts that are there in the field. So the visit is of 1 week, and we check everything, we look at everything. And once again, here, the goal is not to punish, but to grant this transparency and improvement. So we are basically looking at absolutely everything. And this is something also that echoes what has been said at the previous roundtable, because everyone can go to our website, HAS, and you can see, like, if you have a surgery in a certain medical establishment, you can look at the information and see what has happened during this or that certification. So for us, the goal here is to have this transparency. And having this goal in mind, we also have an indicator, and probably you already know it, because this is something that is around the patient experience. One of them is very well developed, and it's called eSatis. eSatis, electronic, because you are receiving text messages on your phone. So eSatis, and Satis is for satisfaction. So we are basically asking our patients here, and we are also giving them the phone number so that they can call us if they have some adverse effects or complications or things like that. And there will be this dialogue, electronic dialogue, that will be going on with the patient, and it's very, very developed. And here we also have a very important part of free comments. And up to now, it was not really easy to use because these were PDFs, so technically it was complicated. But we actually have organized a small contest for innovation and data to make sure that we will be able to use all of this free text, so that to give this information to the teams and to everyone who is somehow involved in the process, so that they will be able to improve the care. So that's just to explain to you our sample. Thank you very much, Fabienne. Now, with respect to CNAM, probably you can talk to us about how you judge the quality of healthcare. How do you measure all of this, and what is the goal at the very core of the health insurance? Well, probably we will judge it from the economical point of view a little bit more than from the point of view of the optimization of the system. I don't know. Thank you very much for having given me the floor. So I'm the director of Insured. So I will not really be talking about the economic point of view. I'm talking, well, we are judging it from medical and economical point of view, but my speciality, my skill is to look at the medical side of all of this and look at the different care and the deficiency parameters here as well. So what I wanted to say here is that this notion of the quality of care is, as it has been said many times today, from the different points of view. We have also introduced the economical dimension, but also medical relevance. And I'm actually very surprised that we can dissociate relevance and quality, because I think that we have to be very careful here. I believe that right now, with all this increase of the percentage of the chronic diseases and for us, basically, the main goal is the outcome for the patient, because the outcome for the patient is the mobilization of the professional resources and also the relevance. So starting from this outcome for the patient, we can basically build up a concept of quality of treatment. And for me, this is quite simple in terms of the outcome for the patient, and I will do it backwards, and this is voluntarily. So first of all, we start by the satisfaction of the patient. And I would like to insist on this, because when we are looking from the point of view of the patient, we are never certain at what we are measuring, whether this is satisfaction, because we will say, yeah, that's so subjective, that's so biased, the patient is always happy and so on. Yeah, well, we can make sure that the patient will be happy anyway. So this satisfaction of the patient is about what? About the experience with the system or the outcome in terms of the quality of life and the real outcome of the healthcare. So I think that all of these concepts should be detailed. So it's not just the point of view of the patient and the satisfaction of the patient, but we have to be much more precise here. And just as this lady has already said, and I wanted to say it as well, it's very important for me. We know that in the scientific literature, the commitment of the patient will become better through empathy and through the relational quality of the care team. That's a key element, and this is a leverage point on which we can influence in order to improve our outcome and our results. So the point number one is the satisfaction. The second point is, of course, the efficiency, the life expectancy, the quality of life. And once again, we're here from the point of view of the patient. And the only person who is able to evaluate their quality of life is the patient. So we have different hierarchies, different tools and rankings, specific tools with respect to different pathologies and groups of pathologies in order to equip patients as well as professionals, associations of patients, with respect to this element. The third element is, of course, the safety. The safety is very much related to the relevance, because this is also, well, this benefit that we get from the care, and all the doctors already know it very well, so we have to be able to do it well. So the measure of the result, I think, is absolutely crucial here for the improvement of the quality of care, because this result can be shared globally. And also there is this question of scaling, because I believe that the errors that we have committed, and, well, I'm part of this us, is reasoned by segment. Then we have hospital, then we have the city, then we have social and medical establishments, and the questions related to the validity, to the disabilities, and so on. But finally, the person is always the same person. So to have this reasoning that is populational, and I will use this term populational, has much more sense for me. Yes, of course, that's a lot of work, an important work that must be done on this topic. But the second important element here, because we're talking about the result, the outcome. So the outcome, when we see a certain alert related to the outcome, so something is not right when we compare it. So this outcome can be global, and then it can be per actor that participates in this care, in this treatment, and everyone can try to understand what is the weak link here. And in order to try and understand it, we have to go back to the structure, to the process, to analyze all of this, and to go back, as Etienne has said, go back to this topic of the organization of the care and coordination that will have the major impact. Now, with respect to the evaluation of the quality of care, I believe that we really have to make a team, just as we are doing it in the care itself, on evaluation, meaning to work in solidarity with all the stakeholders at the level of each and every territory. And I think that this is very interesting, because the practice of care today is no longer individual. It's very, very rarely it is individual, which is why the insurance right now started to do things, let's say, related to heart diseases, and we have already talked about it, with different tools that will be mirroring the tools that are here for the establishments, for the professionals, health professionals, and different teams. So that's the point of view that we adopt in our work, and hopefully very soon we will have the means to also have the part related to the patient in all of this, so that to complete all this analysis that we are doing with respect to the consumption of the care, and also all this clinical data that we have, and this clinical data is also something that is developing, but this is not part of this roundtable. Thank you very much. Thank you, Catherine. And right now I would like to give the floor to Marie-Daudet. Thank you very much for being with us. I see that in Paris the weather is nice, and that's very nice. But here it's even better, so we are very well here. So the DGOS, Director General of Care Provision, with respect to the quality of care. So what is pretty much your mode of functioning? So what is your way of seeing all of this at the level of the ministry? And how can this go into practice, I would say, at the level of the territories, because as Catherine was telling us, this is finally at the territorial level that we will be able to improve this notion of quality of care. Well, hello, everyone. Thank you very much. Yes, indeed, there are many things that have already been mentioned up to now, and I believe that we are all in agreement on the fact that quality must be a fundamental goal of our healthcare system. But we can also say that we still have a lot of improvements to make and a lot of progress to make, because quality today is what really who really participates in the access of the healthcare, access to the healthcare for everyone. It has to be equal and at the level of the professionals as well. And we can measure it at the level of the professionals who are participating there, but also at the level of the patients. We have already mentioned it many times. We have to have a certain measure of the continuity of the journey of the patient, the quality of the hospital, and this global vision must guide us. Then, we have also already said, quality is not a goal per se by itself. It actually depends on a lot of other factors that can guide us as well. And a lot of different notions have been mentioned here, but the quality of the system of care is whether this is relevant, safe, and in a stable environment with the organization that works well and that has means to work well and with all the safeguards. So now we have all of these notions that are notions a little bit different but overlapping. So the quality is being measured, and it has already been said. We have the indicators of quality, of safety of the care, and of course we have already said it. Fabienne has explained it all in very much details, but these are the indicators that should allow us, that must allow all the professionals to adopt their practices and also to analyze the results that are coming from these indicators. So we have the indicators related to the healthcare journey. We're moving forward here because we have the HAS and the CNAM that are working on Health 2022, on the client's journey, patient's journey for the chronic diseases. And we're also looking at the university hospitals, the coordination between hospitals and the city. And we are progressing, even though it's not very fast. We also have some indicators like the vigilance indicators with the reform of the authorizations. And these are the indicators of non-quality, as we can call them. So these are the indicators that should alert us at the territorial level as well, so that we would understand that there are some thresholds that have been broken and there are some practices that must be adopted and improved. And finally, we have much more specific indicators that are related to the financement. And this is also the tool for the improvement of the quality, the model IFAC, which allows us to get the financement from different establishments with respect to the quality indicators. So we have a lot of things that are available for us today. But once again, I would like to say that with all of these indicators, if we would like to move forward, to progress, we have to think about the relevance of the procedures, coordination between the city and the hospitals, and also safety and securization, because we have talked about the certification, but also about the thresholds for the activity that have been also created throughout the reform that we have had, the accreditation of all the health professionals. So we actually have to see how all of these notions can match and work together. And for the DGOS, for us it's important to act on different leverage points, so that to make sure that all the different actions that we're carrying out would actually lead us to the progress, to the improvement, and to the good results, especially in the field. So what are these leverage points? Well, these are the classic leverage points. First of all, this is for the professionals, because the professionals must be stakeholders of all of these approaches and all of these acts. They have to accept to have continuous training throughout their life. So we have this approach of re-certification that is here, so that they would be able to adopt their practices. They also must respect all of the procedures like the accreditation that are here, so that they will be able to move forward within this improvement of quality approach. Then we also have this leverage point, which is the financial one. I have been talking about IFAC already, so we know that IFAC can be reformed as well, and the new reform of the financement of the healthcare establishments that will take place in 2024, that has been presented yesterday, also foresees a very specific point point on the financement of quality, and we have to work on it. We have to advance with respect to this point with everything that has been said. And the third point of leverage is the participation of the user, the action of the user. And I think that we have already talked about it throughout this round table. And it's important here to talk about the satisfaction of the users, the efficiency of the procedure that has been done to this or that user, and all of this in order to improve the quality. So for PREMs and PROMs, we start to look at all of it from the point of view of HAS, and we see that all of these practices are much more used abroad than here, and we understand that there is a lot to be done and to improve here. But this is this approach that makes the user at the very heart of the quality, and this is something that will allow us to have real results that will be related to the healthcare professionals. Thank you very much for this explanation. It actually makes me react in two different ways. The first way, well, I don't know whether Françoise agrees with me, but the role of the patient becomes very important here. It's kind of like the very center of our discussion. And this is like the rarest animal, I would say, because we are turning around and looking around, but fundamentally, I think, and I believe you agree with me, we don't really find for now this co-construction space with the patient. And the second thing that I can find is that we have an absolutely wonderful kit tool, but if we don't have someone who will be working with these tools and the management of these people and the implication of all of these people in the field, there will be a huge problem. And that's the problem that we have for 20 plus years. Well, Françoise and probably Daniel and Fabienne, I'll give you the floor. Yeah, you're talking about those who will be working with these tools, the craftsmen, I would say, in the field. Yes, indeed. And I would like to emit a recommendation here, because I have a lot of friends who are doctors who say, yeah, the recommendation, this is very complicated. So we have this point as well. So if I would like to take as a proof the strategy of the transformation of the healthcare system, we have participated there with the osteoporosis. And finally, not only, nothing changed, but yeah, of course, we continue to work together and to have this discussion about other diseases. But the situation actually degraded. It became worse. We have 4.8 million of women who have osteoporosis. And right now we are progressively coming, like this number is climbing up. And the pain is catastrophic here. Nonetheless, this is the case for all the people who came to see me. And they were like, please do something. Yes, we will do it all together. So the real life is incredibly important. The health of women, I also wanted to talk about it, because right now we are being more and more aware, because you're right, the health of women is also an incredibly important topic, and we have to work on it, because yes, indeed, we have this inequality, and in the field we have to work on it. We have to be courageous and to do something every single day, because this is part of what we have to do. So we have to be courageous and to move here, to move and to act, really, because in reality this is the journey of the patient. So everyone who came to see me to say that does not work, it's all bad for me. And this is a huge drama here in France. And that indeed goes back to what Mr. Picard has said. I have appreciated a lot what you have said. And also what I wanted to say is that this treatment and it must be done among the professionals, and this is not something that is absolutely aligned here, because everyone, all the professionals, they have to stop this fight at the background. We can be much more performant with the patients, because otherwise we leave some elements aside, because there are some important elements that are part of the patient's journey. So we don't have to forget about it. We have to work together with the patient. Yeah, we have this 4 million patients every single day. Daniel, yes, I wanted to say about this craftsmen, as you called them, because they do exist in the field. Like, let's say we're talking about the nurses. We have created this approach, quality approach, 8 years ago, and we have integrated into this approach approximately 1,000 different offices, because we are organized per office of practitioners, and we have 3.5 practitioners in average per office. Well, this is not sufficient, yes, of course, but this quality approach goes back to what I have said at the very beginning. It means that we are persuaded that we have to create a favorable ecosystem so that later on we will have these notions of quality of procedures, quality of care, and so on that emerges. So we have this particular approach that is based on criteria with audits, and this audit is basically the what we're looking at different samples, and then we're doing these calculations in order to understand the situation. And we will help the professionals so that not to punish them, but to do this follow-up and to help them improve the indicators. And we started from one statement, basic statement, which is that we will not create additional constraints, but we will screen all of the regulatory framework and legal framework and see whether these professionals will be in compliance. And we actually understand that not all of them are in compliance. So we do the follow-up for them to help them out. So we are creating an ecosystem that will be in favor to the emergence of the quality for the procedures. Why? Because when you have this office with multiple practitioners, well, we will not be acting in the same way than when we will be working alone. And this is a very important particularity. We will not be closing our offices Friday so that to close them on Monday, because we are taking care of our patients from Monday till Sunday. And it actually made us create these offices that will have a lot of different practitioners. So we will always have our peers that will be looking at what we're doing, and that is for many years. And this exists today. We are not the only one to do this, because the pharmacists are doing this, biologists as well. Well, of course, there is this accreditation and certification question for them, but this is not a primitive approach for us. This is something that exists. Nonetheless, it actually requires a certain organization and a certain follow-up. Of course, I will just give you an example because I heard the recommendations of the French Superior Health Authority. We understand totally how all of this is working with the SNP today, with the single window approach, and we have this certain degree of maturity, and depending on the profession, they're not the same. But just to give you an example, for the nurses, they have over 600 professionals, and it's less than 200,000 euros of budget. So that's not a lot. So will we be able to ask today the CNP to satisfy all of this order with this budget? Because quality approach is also something that requires funds. Yes, indeed, we have talked about it with Marie and with Françoise, because we were talking about the patient journey and what was also targeted in Health 2022 that I have mentioned. Well, I haven't talked about this topic in particular, but we have some data in HAS that tries to capitalize on SNDS, the National System of the Health Data, so that's the acronym, and which is part of the data that comes from the reimbursements, and it allows us to have the information. So what we tried to do here is to make sure that the recommendations and best practices will coexist, and these practices are basically created with all the professionals and the patients, and the method here is very transparent and participative. So we tried to align it with the reality of the field, and we also did it with the PBCO, and that's the very first topic that has been developed by our French Health Authority. I'm looking at Catherine here because she was working with me on it when she was on her previous job position. And that was a very good development because it allowed us to have the source codes in open data, so that to say, well, this is an ideal journey with what we can see in SNDS, well, the National Healthcare Data System, and what we can tag. So these are the source codes, and for the IRS, they can later on use all of this data to see whether there are some gaps and things like that. So you have used this term of craftsman. So to see that probably there will be some gaps that are not breached in a certain territory. And the idea for us here is to adopt the regional health strategy by using all of these journeys, everything that we have in open data, to see what is lacking in each region. Well, of course, this is not magic. This will not make appear healthcare professionals if they're not there in this territory. So that's still the problem. Nonetheless, it still gives us a certain information about important gaps that we can have in the patient's journey. And it also gives us a broader scope so that we're not just limited by the segment of city or hospital, home, because the home is also an important component here. So we're trying to look at the journey in general and to see what can we add and where can we add some additional attention, probably per territory. Frédéric, from the point of view of the Scottish guy coming back to France, so what's your vision? Is it like a brutal landing for you, or what do you mean by that? Well, I see that there is a lot of work that has been done, and very often I also understand that it's also the implementation of all of these measures that is kind of complicated. But I probably wanted also to use this couple of minutes that I still have to talk about audits and all of these measures, because all of these are tools that are very important. Our hospital is making more than 4K prostheses per year, and they would like to go up to 7K, which means that it will be approximately 50% of addition and approximately 50% of all the prostheses that will be in Scotland. So it's like, I'm sorry, a plant for prostheses, a factory. I'm sorry to use this term, but in reality, this is pretty much how it is, because it requires a lot of very good organization, but also the evaluation, the assessments that are continuous and permanent. Just to give you a couple of examples. Well, first is the level of the patient. So all the patients are met. They have the appointments before the surgery. So they will go to see absolutely all the practitioners, everyone in one appointment. They will go and see all of the professionals there. And this is due to the fact that most people will come from the geographically remote areas with respect to the hospital. So we have to optimize all of this. And then there is this report, which is made before the surgery. And then there is this report of what has happened during the surgery. So this will be like the discharge after the hospital, when they leave the hospital will be organized there. So then we talk to the pharmacist, and we are organizing the audit here so that to see what will be the role of the pharmacist, because we also have some pharmacists that are working in the hospitals permanently. And we have seen, after having audited 500 patients, that 25% didn't have the right dose, 25% did not take it at the right moment, 15% of people had some medical associations and they actually thought that it was not good. So what does it mean? It means that the risk of the complications and side effects increases a lot. So it's been 3 years since we started this system, but right now we have this pharmacist that is working right now closely with everyone and with all the teams that are here to organize all the medicines, all the drugs that are necessary when the patient leaves the hospital. So it's all done in collaboration with all the other teams. And the second point I wanted to insist on is for the staff. For the staff, we have the audits that are organizing continuously and permanently. For example, we are distributing randomly 50 questionnaires to the patients that you just see here in front of you, so you don't really know who they are. And they will give their opinion on the quality of your care. And then there will be an assessment that is called 360 degrees, meaning that you can be evaluated by all the stuff that works around you. This can be your colleagues, nurses, that can be caregivers, and so on and so forth. And this assessment is mandatory every 4 years. The very last thing is the institution. The institution will record all the data. They will do it in an independent way, independently from the surgeon. And this is also a very important element, so that to motivate people to have good quality, because whenever we see that we have much more complications, side effects, adverse effects in one place, where we have additional revisions, let's say, for the knee prosthesis, so it actually makes us send this prosthesis back and go to back to the institution. So these are all the measure tools that we have here, so that to evaluate. the system. This is very impressive, and I believe that it will be great for us to be inspired by this model, especially in the field. Catherine, you have talked about the topic that is incredibly important, that we have the care, but we also have this overall care when we have an elderly person who is in the elderly person institution, EPAD, or probably somebody who is disabled or a child who has a very rare disease. So we should have this care that will be much more holistic. So how do we do in order to bring together here the healthcare professionals and the establishments? Well, I think that for us it's important to start by the outcome for the patient. And if we start by the outcome from the patient, here we can have this holistic approach, because this is basically something where each and every actor is participating with respect to the outcome. Well, the difficulty here is to be able to practically divide it between all the different actors correctly, but I think that we can work on all of this. And I think that it has to be multi-professional, multidisciplinary, and we have to take all of this into account. We have many different initiatives in this respect. I also wanted to say that we have many initiatives in France in the field as well, at the level of the pluridisciplinary healthcare institutions and other healthcare institutions. Many things are done. But finally, they have an impact on the local practices, and this is very good. But unfortunately, this has no visibility at the overall level. We cannot really compare the results at the overall level, because apart from small special cases, we don't really have this global vision. But that's fundamental for us to start from the outcome for the patient, because that will cover up all of the dimensions. And the healthcare space will also serve to this. Mon Espace Santé, my healthcare space. Will this help it? Yes, of course, because this will facilitate the coordination of all the care and also the coordination between the patient and the healthcare professional, because it's not always very easy to have a healthcare professional, let's say a general practitioner, a specialized doctor, a nurse, and a caregiver. So this is something that is accessible to everybody who is interested in the care of the patient, but also that the patient would agree to share their information with. And this is a tool for the ministry, so that the ministry will be able to pass on all the different messages related to the prevention, and they're targeting people per their group of age, per their sex, and so on, because that's very interesting to see whether there are some patients with respect to their pathologies and so on, and if they agree to have their data as well. And I think that this will be very useful also to target here people with chronic diseases, so that to tell them, let's say, to get a vaccine against the flu or something like that. But we can actually have a lot of different initiatives around this topic, and I think that Mon Espace Santé, so my healthcare space, can allow us to integrate all the referenced factors and criteria with different tools. So it will be like a centralized point, a hub for us. And it's very promising to help us to simplify and to take care of patients in an integrated, holistic way. Marie, I would like to ask you this question with respect to everything that you have heard, especially the experience of Frédéric. How do you see things? Will we continue to have these indicators as they are, or will we be able to find probably a little bit more managerial approach here to do the follow-up for the hospital teams and also create links between the city and the hospital, medical and social, so that to make sure that this journey becomes reality? Because as Françoise just said, right now this is not a reality. Yes, indeed, you have already said it. The toolbox exists, and we also have a lot of indicators that exist. Right now, what's important for us is to really explore all the ways that are here for us. We have to develop the role of the user, and this has been already said, and I think that it's important to underline it again. The fact that we can measure our own health and to see also whether we can go back to a journey, healthcare journey or not, I think this can be really, really useful. But we have a lot of progress here. If someone had a very successful surgery but a bad re-education because there was not no good cooperation between the city and the hospital, of course, the outcome is not good. So we have to think about the role of the user, but also about the coordination and the role of the medical journey, of the healthcare journey. We will be able to move forward. The second leverage point, as I said, is the financement. So we have to take into account quality when we're talking about financement. And the third point that we haven't mentioned a lot up to now, but I tried to introduce it as well, is quality for quality is worthless for us. A procedure that is not relevant, even if this procedure is well done, finally, the outcome of the patient, even if the patient says that he or she is satisfied, it won't achieve the individual or collective goal, which is why, objectively, well, I think that today it's still problematic. We haven't really moved forward with respect to the relevance of each procedure. So we have to somehow converge here to have a better to take better into account the outcome by the user and to create a much more efficient journey and also work on the relevance of all the procedures. Why a procedure? So you still have like 30 seconds. Yeah, I wanted to go to what Marie has just said, what is also very, very important. At the High Health Authority, we are talking about the relevance of procedures, and we also have this mission data, and we have created several files with respect to that. One of them is with respect to the knee diseases and to the radio of the knee, the scanners of the knee, and we actually found out that a lot of them were useless. And the other one was also with respect to the shoulder scanner. And these were actually two tools to measure the X-rays, let's say, for these examples, and just to put a certain concrete figure with respect to this relevance. Yeah, so we are actually advancing in the right direction. So, Françoise, unfortunately, Guy will be angry if I give you the floor. Guy says that it's over. So, yeah, we have to stop here. Sorry.